Good morning.
Morning.
My name's Dr Vishal Luther. I'm a senior electrophysiology and device trainee at Imperial College Healthcare at the Hammersmith. And I'm talking today on heart failure because I see patients with heart failure as a result of doing catheter ablation for patients with atrial fibrillation heart failure, or VT ablation for patients with heart failure, or implanting defibrillators or CRT.
Hi, I'm Eileen Porter. I'm a patient. I've had AF for years, but I also have a nursing background. Well, I've been told that I've got heart failure, and I wondered what it involved, what sort of symptoms I can expect and what sort of treatment I can expect.
Okay, so heart failure is a condition where there's an impairment of the heart structure or function, which means that each time the heart beats, less blood gets to the rest of the body. And there are many different causes, and the symptoms people get are as a result of less blood getting to the brain or to the body, which means that it can feel tired or weak. Blood then backing up on the organs beforehand. So if it goes back into the lungs, people can feel breathless, or backing up all the way down to the legs, and they can get things like ankle swelling.
I think mine's due either to my pacemaker or to the AF, but I didn't know I'd got it. It was suddenly told to me after an echo. And I don't really understand what's going on, except that I get very, very breathless, which I don't like.
So yours was from AF, and so talking about the other causes. So AF is one of many causes. The most common cause actually is if you have a heart attack. So if you think about it, after a heart attack, part of the heart muscle is quite weak. And as a consequence of that, each time the heart beats, less blood comes out. And then things like high blood pressure for a long period of time. You've got that too. So blood pressure for a long period of time puts a kind of a strain on the blood pumping out each time. And so the heart can remodel in a way it doesn't like to, causing weakness. And then there's some conditions which people are born with, which can manifest much older in life. We call these hypertrophic cardiomyopathy, things like that, or dilated cardiomyopathy. And then some conditions where the heart becomes weak because of another condition, things like sarcoidosis. And then there's things that we do, like alcohol in extreme excess, or some drugs. So chemotherapy, for example, can cause weakness of the heart muscle. And as yourself with AF. So AF itself tends to cause weakness of the heart muscle if the heart has been beating fast for a long period of time. It's kind of like a mini marathon. It's the heart's been running fast and fast, it gets tired, and then it can become weak. So there's lots of different causes.
So what treatments might I expect?
We kind of divide the treatments up into three things. So it can be the things that you can do yourself without needing anything from a doctor. And then there's the things that the doctor can provide. So that's usually drugs or kind of interventional procedures. So the things that you can do yourself are actually really powerful. So, and that involves things like appropriate diet, physical activity. And I wouldn't say, regular exercise, because I think for some patients, regular exercise is quite hard to do, but actually just some form of physical activity is good. Smoking cessation, reduction in alcohol excess, if that is a cause. So those are the sorts of things. And to help in that, because that's not easy, patients with heart failure should be offered something called opportunities to meet in a group to discuss this, and we call this cardiac rehabilitation. Within all areas, there's these kind of opportunities to meet and have tailored education, guidance on diet and exercise. So that's kind of one part, and it's a really powerful part, and you can really help with that. But it's easier said than done. And then there are drugs which can help, and there's basically three big drugs. One is called a beta blocker. Can't take those. One is called an ACE inhibitor, and one is called an mineralocorticoid antagonist. So those have been well proven, well studied, and highly effective in reducing reduction in mortality and hospitalization. And then there's this new, it's been labelled kind of as a wonder drug, this thing called Entresto. I don't know if you've heard about that, which is only there for a small cohort of patients. Currently, certainly in the UK, it's for patients who remain symptomatic despite the above medications I've described. Then if they've got significantly impaired ventricular function, then they may be offered that drug too. That's kind of the drug side. And then there's the kind of invasive interventional things, which for arrhythmia is something that I do quite a bit of. So, and that's kind of dependent on the cause. So if you've got heart failure because of blockages in your heart arteries, well, a stent or bypass surgery can help. If you've got heart failure because the valves have all aged and become kind of thick and calcified, then there are procedures to fix that. There's something called TAVI, which you may or may not have heard of, and or valve surgery. And then if it's an arrhythmia problem, so there's a lot of good data now for heart failure and atrial fibrillation for catheter ablation to try to get people back into normal rhythm and keep them in normal rhythm. So that's kind of tailoring it per the cause. And then there's the generic interventions that we do, and those are predominantly device-based. So if you have a significant weakness of your heart muscle, we're talking about something called an ejection fraction. I'll talk about ejection fraction in a moment. So it's an ejection fraction of less than 35%. Then one can be offered something called a defibrillator. And that won't make you feel any better. What that is, it's there to protect you from dangerous heart rhythms, which we know can come about when the heart muscle is weaker. And then there's another type of device called CRT, cardiac resynchronization therapy,
I've heard of that.
which you've heard of, and I think they were considering offering you, but I think your ejection fraction was just above at 40%.
Yeah.
So you're right. So patients who have ejection fractions below 35%, and they have to have another condition where they have abnormal electrical movement through the heart, and that's as a cause of something called bundle branch block. Now in you, because I know you have a pacemaker, bundle branch blocker is because you are paced, but there are some people who have bundle branch block just the way the electricity moves around the heart, and it's quite common as you get older. So in that cohort of patients, when they've got bundle branch block and they've got a weakened heart muscle, there's a special type of pacemaker it's called resynchronize. It makes the right and the left side of the heart pump at the same time, which is very effective in reduction in all-cause mortality, hospitalization, and improvement of symptoms. So that I would kind of say is the treatments available for heart failure as a constellation.
Right. In my case, the exercise was a problem because if I exercised and increased, I went into AF.
Okay.
So I used to have to avoid that, and that was before the breathlessness started.
Yeah.
And now, the more exercise I do, the more breathless I get, and then I feel really quite ill.
Yeah.
So that puts, as far as I'm concerned, the exercise out of me.
Yeah. And I think that, as I say, I think exercise regimes specifically are difficult to adhere to and follow because they can be quite complex. But actually, the key word is tailored. So it's tailored to what it is that your condition and what you have. So just some degree of physical activity, really, whatever it is proven to be effective. Granted, it is difficult to achieve in as many situations and circumstances.
Like walking up and down stairs.
Yeah.
So how do they decide, or you decide, that I've got heart failure?
Okay, so the diagnosis of heart failure starts with basically at the bedside with a history. So just taking the symptoms of heart failure. So we talked about breathlessness, we talked about ankle swelling, we talked about tiredness, weakness. And the breathlessness is very particular. It's particularly at night time lying flat. And then sometimes you need to sit up to relieve that sensation of breathlessness, or effort limitation when you're walking. So these kind of constellation of symptoms can give a physician the clues that you might have heart failure. But remember, there are a lot of other conditions that can do that. So then there needs to be more testing. So the next thing one would do is an ECG. Now, for me, the ECG is like a kind of a camera or a window towards the heart and gives you a lot of information about whether the heart is normal or abnormal. And that would be test one. And then the second test one might do is a blood test. There's something called BNP, B-type natriuretic peptide, and there's a variant to it called NT-proBNP. Now, whatever they are, these two blood proteins are released into the circulation when the heart muscle is under stretch. And so they are a very good indicator if the cause of one's symptoms are related to heart muscle problem. Now, be cautious in the interpretation, because actually they can go up in a lot of other conditions. But what a GP is advised to do is if a patient has the symptoms of heart failure, if there's some concern on the ECG, if the blood test is raised, then they're encouraged to refer patients for an echocardiogram at that point. If it's very, very raised, that blood test, they need to get them for the echocardiogram fairly swiftly. It's around about 2 weeks. Otherwise, it's about 6 weeks. And then it's really on the echocardiogram that gives us an understanding of heart failure. Now, there are two types of heart failure that can be diagnosed on an echocardiogram. The one that we all kind of understand is where there's a problem with something called the ejection fraction. That's a really key term to understand. So the ejection fraction is as follows. So each time your heart beats, the main pumping chamber that's going out to the rest of your body is the left ventricle. So remember, there are 4 chambers of the heart, 2 in the top, the atria, 2 in the bottom, the ventricles. And it's that left ventricle that pumps blood to the rest of the body. And it's a problem with that left ventricle which causes heart failure. And we can see that on an echocardiogram. Now, a normal ventricle only pumps out 60% of what it fills with. That's what I mean by that. So if the ventricle were to fill with 100 mils of fluid, a normal ventricle will pump out only 60 mils of that. That's normal. People worry, it's 60%, and is there a problem? No, that's normal. We diagnose heart failure with what we call reduced ejection fraction when it's below 40%. So if it were to fill with 100 mils, then heart failure, the traditional diagnosis of heart failure is if there's a reduction where the ejection fraction it's only pumping out 40 mils each time. Then there's a cohort of patients where it becomes a bit more complex and a bit more confusing, where they can have the symptoms of heart failure and they can have an increase in that blood test, that BNP. But they actually have an ejection fraction which is above 40% or almost normal. And then it becomes a bit unclear, do they really have heart failure or not? And so now there's this new entity where one can be diagnosed as having heart failure with reduced ejection fraction, less than 40%, or preserved ejection fraction, which is greater than 40%. And the reason why that kind of condition exists is because the problem there is not so much how much the blood pumps out, it's there's a problem with it filling. And the key thing is the filling. So if you were to imagine a normal heart fills with 100 mils and pumps out 60 mils, there are some conditions, especially things like high blood pressure, which stops it from filling so much. So it may only fill with, let's say, 80 mils. It still pumps effectively, but by definition, the ratio, that numerical value will go down. And so still the absolute amount of blood that pumps out each time is reduced, and they can still have the same symptoms. So it's the diagnosis of heart failure isn't black and white, it isn't easy. It's clear cut when the ejection fraction is low, but when it's about higher than 40%, you can still have the symptomatology of heart failure, but and that diagnosis can become quite complex. And we see that a lot in atrial fibrillation as well. So Eileen, today is the patient day at the Heart Rhythm Congress. Can I ask why you've come to the patient day and what you hope to understand, learn and observe here?
When I first started coming, it sort of taught me all about AF and what I could do about it or not do about it, what I could expect. And then I've continued coming because it gives you a heads up on the new treatments coming out, and also you can get involved in other things, or I have, as a result of coming to the Patient's Day, all which broadens your knowledge of your complaint.